May I request Dr. Saluja to please come and start his session. Basically, it's a norm that the moderators introduce the speakers, but we have kept it very simple because हर आदमी अपने बारे में जितना जानता है उससे अच्छा कोई नहीं जानता. So I request, sir, to introduce yourself and please start. Yeah, thank you, sir.
Okay, so a very good afternoon to everybody. I am thankful to the organizers of TASCON for giving me this opportunity to speak on labor analgesia. First off, I'd like to thank Dr. Anjan Trikha, though he's not here, but he introduced me to labor analgesia a long time ago. And he also helped my wife deliver our eldest son in a very comfortable manner. And ironically, it was she who made me actually go after labor analgesia, and she made sure that I learnt about it and I practiced it. So it was very helpful. So when I had to get up at night, she never used to say no. Okay, now the time for labor analgesia has come in India. Its demand is growing. The graph is going higher than our Sensex, and it is the hot topic. Also, the availability of regional anesthesia for labor is considered a reflection of the standard of obstetric care of either that institution or maybe of that country. So you're going to have a young girl, or maybe not so young girl, in her late 20s or early 30s coming to you. Confident girl, she knows about everything, she probably controls everything at home. And this is one thing she has no idea about. She's about to become a mother and she's scared. She's scared of the pain that she's going to have and she doesn't know how to handle it. She comes from a nuclear family, there is no family support, and she really doesn't know what to expect. Obviously, if she is a second gravida, has a previous successful epidural, then the battle is won. You don't have to do anything. She'll start asking for an epidural in the casualty itself. Information is what makes the urban ladies more wanting an epidural. If you give the same information to all the people who are there in the rural areas, believe me, the same ladies will ask for an epidural, so it is all to do with the information divide. What they want to know boils down to two major questions. What is the effect on the baby, and what is the effect on me? Primarily, will I have back pain afterwards or won't I have back pain? So how do you approach this thing? First, you have to be very well read. You should have verified facts and figures. If possible, have facts and figures of your own institution, if you have the numbers to prove. Even then, whatever numbers you have, make sure you have them. She has probably read everything. She knows all the side effects. Mention everything. Mention there was nerve damage, spinal cord trauma has occurred. There have been incidents of headache, backache has been reported, and you should know how to handle her questions. At the same time, mention that there have been failures. It is not 100% guarantee that she will be totally pain-free. You have to let her know that it is your aim to keep her pain-free until she's almost fully dilated. After that, you will try and keep her pain-free, but it depends on how she progresses, how she is handling the pain at that time. I find it very easy to ask, or very comforting to ask, that how well has she done her antenatal exercises. I said, if you've been doing your antenatal exercises, maybe I'll be able to give you complete pain relief until you actually deliver the baby. Fetal bradycardia is something that is mentioned in the literature. Be sure that you mention it. Also say that it has not been found to be sustained, and it has been proven that epidural as such has no effect on the baby. Talk about the fact that the same epidural will be used to provide anesthesia for her cesarean section if it is required. But convincing your obstetrician is another ball game, right? 99%, the only reason why she's coming to you is because her patients have been after her. They've been probably after her life that, ma'am, I want an epidural. Ma'am, I've heard there's an epidural. It can be done pain-free. I want to do it. It is best if you have been working with your obstetrician for some time. There should be a bond of trust. Fortunately, all good gynecologists begin to trust their anesthetist, that they'll trust their anesthetist more than what any physician or what anybody else will say. If you have such a bond, it is very easy to convince her to accept the idea of a labor epidural. You should be armed with the facts and figures. Cochrane reviews will help you. You will have all the facts, all the numbers given over there. I'm not really going to waste a lot of time on that. But you have to accept what we know. You know that the second stage of labor will be prolonged. There may be an assisted vaginal delivery, and at least initially, if you're introducing epidural at a new place, you should have an on-site anesthetist present throughout the labor process. When I started in 2002, for 5 or 6 hours, I used to be sitting with the patient, making sure she was pain-free, and it took about 2 years for me to convince the gynecologist that I knew what I was talking about. Now you finally come down to initiating labor analgesia. It would be better if you have had a pre-labor interaction with the patient. Fortunately, at Cloud9, we do get an opportunity to talk to the mothers sometime in their 6th or 7th month, and we are able to prepare them with what we want. You should know what she wants, what she's expecting, so that she doesn't have any false hopes, and you can sort of tell her that this is what is going to happen. Let her know that your services are available round the clock, so she's not scared that she has to approach you within a definite time. That itself will put her at ease. Now, just a brief overview. We know that childbirth preparation and education began with Dick Reed a very long time ago. And it was his same ideas were taken up by Lamaze, where we have the Lamaze technique of providing analgesia. It is actually giving relaxation training, telling the patient how to breathe, and making her mentally aware that she's going to have pain, and trying to turn this feeling of pain into something that she's going to achieve something positive. She's probably going to get the biggest gift of her life, and maybe that pain won't hurt. But believe me, at 5 centimeters, all this training goes for a toss. At that time, it doesn't matter how she's breathing or what she's doing, she just wants the pain to go. Now, to complete it, you have massage. Massage actually helps, and if you have a support person present in the labor room with her, a massage and that feeling of touch will help alleviate that pain. I use a synonym. I say that these sisters over here are the strongest sisters we have. Hold their hands and imagine you're transmitting all your pain to them, and they'll be able to take it. Now, the pharmacological techniques include the commonest drugs used are opioids. I'm mentioning it because it is given in the books. You'll probably read about it, but I personally have never vouched for any opioids, and I don't know any obstetrician who actually uses opioids nowadays. No drug is better than the other, but if you have to give something, I would suggest that you give fentanyl. Fentanyl has been found to be the safest drug with the least neurobehavioral effects in the neonate. I would suggest that you should know about the doses, because maybe your obstetrician will ask you. When it comes to doses, the anesthetists are the best person. Nothing is given without your say-so. A short note on remifentanil, not yet available as such commonly. I haven't used it, but in all the reviews that I've read and whatever experts I've heard speaking, it is an ultra-short synthetic opioid. It is something where if regional anesthesia cannot be given, you can use remifentanil. It is metabolized extensively by the tissue and plasma esterases and is also metabolized by the fetus. Even this will take about half an hour for you, giving it as a gradual infusion until you get a patient who achieves a VAS of less than 3. We are all inhalational therapists from the beginning, so let us not forget Internox or Cevox. Nowadays, especially with the onset of COVID, once COVID started, Internox went for a toss. I haven't seen it being used in the past 2 years, and nobody actually opts for it. They have a poor analgesic efficacy. There is a concern for environmental pollution, and the only thing actually is it helps you feel that you're doing something for the patient. And maybe she spends so much concentration on debriefing the Internox that she feels she forgets about her pain. But again, once the labor progresses, Internox has not been found to be effective. So what do we actually do? The most versatile and the gold standard in labor analgesia is regional analgesia. There are various modalities which you can use. There is a lumbar epidural, a combined spinal epidural, then only a lumbar epidural with a plain dura puncture. You have continuous spinal anesthesia, either with microcatheters, or if there has been an accidental dura puncture with your Tuhi needle, put in your epidural catheter into the subarachnoid space. Or for very late labor presentations, you can give a single shot spinal. I have used mainly two drugs. 3 are recommended: bupivacaine, ropivacaine, levobupivacaine. Presently, it is easy to get bupivacaine available all over the country. Ropivacaine is making an inroad, and in equianalgesic doses, it is the same as bupivacaine. Lignocaine has specific uses right at the end, maybe if you want sacral analgesia or maybe for episiotomy repair. For the opioids, let us concentrate mainly on fentanyl, which is what is available everywhere. And a short note on tramadol. Tramadol is again in a few countries, developing countries like ours, tramadol is easily available all over the place. Doses of about, let's say, 5 milligrams per ml of whatever you're using, either ropivacaine or bupivacaine, have been found to increase the efficacy of whatever infusion rate you are using. I used tramadol initially from about 2002 to 2012. After that, I started making provisions of fentanyl, which I used to keep with myself, and use that consistently. Even now, sometimes I do resort to tramadol if fentanyl is not available. So now, how do you prepare for neuroaxial anesthesia? You have a checklist, make sure that you roll them out. Most important, make a review of the labs, make sure that you see the platelet count, see the hemoglobin, and check for your prothrombin time. A lot of your patients may be on anticoagulants, a lot of them may be on low molecular weight heparin. In fact, if you're looking at 30 plus ladies, about 40% of them would be on low molecular weight heparin, and please see when they receive the last dose. Check all emergency drugs and equipment. A tragedy can strike at any time, and there is no time to run after equipment at that time. If you are not routinely using epidurals, make sure that all emergency equipment, your laryngoscope, the ambu bag, oxygen, everything should be available over there before you proceed. You need a good lifeline, therefore a good IV line is essential. And before you start, make sure you perform a team timeout, make sure everybody knows their roles, and make sure everything is available. A small note on positioning. Until 2012, I used to do epidurals both in lateral and in sitting. After that, I use only the sitting position. It is much easier, much more comfortable for the patient. It's much more comfortable for your OT assistant, who doesn't have to hold the patient with both hands. You avoid aortocable compression, and it is comfortable for your mother as well. The contraindications to all epidurals is by and large the same, but be careful of recent pharmacological anticoagulation if it is there. If there is any uncorrected maternal hypovolemia, make sure that her volume status becomes euvolemic. Preloading of patients before the epidural is out, so it's basically co-loading, but make sure she is not hypovolemic. If you have untrained staff or inadequate resources at any center, if you have suddenly been called to a nursing home that you want the obstetrician wants a labor epidural, but the staff is not adequate or there is nothing else, then I would suggest you refuse. Now, once you've reviewed the checklist, sometimes you might have the patient's attendant or the husband or the mother inside with her at that time. The amount by which you raise the gown I have often found to be a problem, whereby the attendant always says, is there a need? So before you start, make sure you tell them that her gown will have to be raised and you will have to clean. I think if there is a preponderance of male anesthetists or male OT staff is there with you, there's a slight hindrance. So if you have told them from before that the gown is going to be raised, at least you get over one problem. You start co-loading with a balanced salt solution. You position the patient with the help of an assistant. We have found it very easy that we give them a pillow. We tell them to hold the pillow to their chest and hunch themselves over the pillow. I normally use the L3-4 interspace, though L3-4 or L2-3 both have been found to be effective. I find the L3-4 interspace to give good sacral analgesia afterwards, and it's actually easier to insert. Once you've fixed your epidural catheter, make the patient lie down. You can put her in the lateral decubitus position and initiate monitoring. Now, test doses in epidurals are there. Many people say that in a labor in obstetrics, you really don't need a test dose. And you have to remember that each dose that you give is a test dose because the catheter can migrate at any point. Whenever you have to give a bolus of about 5 ml of a very dilute solution and see for the effect. Literature mentions that you can use small volume or high concentration local anesthetics, either bupivacaine 3 ml or 5% or high volume with a low concentration. And these are the various epidural test dose regimes that you see. I personally have not used a test dose for a labor epidural for the past 5-6 years. Every test dose every bolus that is given is a test dose, and that is how we proceed. Now, how do you initiate labor analgesia? It depends what technique you are using. If you are using a continuous epidural without a spinal component, I use 0.1 to 5% bupivacaine with fentanyl, and an initial dose of about 8 ml is given, and we see the response. If a CSE is given, then fentanyl has been given intrathecally, about 15 to 25 micrograms, and then we start a low concentration of local anesthetic, either ropivacaine or bupivacaine, at about 5 to 8 ml. Literature says that you start at about 10 to 15, but in the initial stages of labor, giving such a high dose will result in motor blockade later on. If you're going in for a simple spinal anesthesia, this is usually if your patient presents at about 8 to 9 centimeters and she is adamant she wants something, then a single shot spinal with about 2 milligrams of bupivacaine and 25 micrograms of fentanyl will give you about 2 to 3 hours. And normally she will deliver in that time. What are your goals when you want to maintain labor epidural? Try and keep the patient as pain-free as possible. We aim for a VAS of about 1 to 2 or to 3. Normal hemodynamics. Monitor the fetal heart rate continuously. And keep the patient's morale high. You have to keep visiting her. If you are in a hospital, dedicated obstetric hospital, we visit the patient every half an hour, 45 minutes. We make her know that we are concerned that she shouldn't have pain. And sometimes if the pain relief is less, the fact that you're continuously going to visit her sort of makes her feel, Doctor Sahab, aapne to koshish puri ki thi. So at least you're not blamed for something afterwards. We normally use 2 drugs for maintenance. We use either ropivacaine 0.1% with fentanyl about 2 micrograms per ml, or bupivacaine 0.0625% with fentanyl 2 micrograms per ml. We start at about 5 to 6. As the patient's pain increases, we gradually go on increasing the dose. So what do we do? What I do? We use either a continuous epidural or a CSE. Patients well established in labor, I use 15 to 25 micrograms of fentanyl for the intrathecal part, and start with ropivacaine 0.1% with fentanyl 1.5 to 2 micrograms per ml, right? And this is started about 5 to 6 ml per hour, and this continuous infusion goes on. The patient is monitored continuously, and as soon as she complains of any increase in the intensity of her contractions, we give her a small bolus and increase the infusion rate by 50%. We know that the effect of intrathecal fentanyl will last for about 90 minutes, and that is the time we have to establish a background infusion. It is very important to know that at about 6 to 7 centimeters, she is suddenly going to have a sudden increase in her pain. This is the time, either if you can anticipate, you already give her the bolus, or if she starts having that increase in pain, give her about a 10 ml bolus of about 0.1% ropivacaine or 0.0625% bupivacaine. As soon as her pain goes down, she will almost suddenly dilate. So rather than decreasing the infusion at this point, at about 6 to 7 or 6 to 8 centimeters, you have to give her that bolus, and that is keep her pain free, and that is when she will dilate at once. If the patient is already about 6 centimeters dilated, is in severe pain, then I add bupivacaine to the intrathecal component. I add about 1 to 2 milligrams. If the literature says about 2.5, if you give 2.5 in our ladies, they're going to have motor block. So for us, about 1.25 milligrams works out fine. If the patient is in early labor, I sometimes don't give the intrathecal component, and I just proceed with the continuous epidural and give her a higher dose of fentanyl in the epidural route, about 25 micrograms straight off, and then start the infusion. Literature says that you can give lignocaine, about 1% at the end, for sacral analgesia. But if you have been giving a low dose ropivacaine or bupivacaine with fentanyl and have been increasing the infusion rates as the pain goes up, I have never found any need to give lignocaine. I allow the surgeon to give local infiltration for the episiotomy, and after that, if she needs some support for the suturing of the episiotomy, that is when I top up with 2% xylocaine. Throughout the labor, she is allowed liquids. She is allowed clear liquids, coconut water, apple juice, and water. And she is NPO for solids, tea, and coffee. Okay, this I'll show after. Now, just one thing, just like to show that usually when I clean the whole back right until the top. What I like to do is to see the whole spine when I'm giving it. Sometimes when you see that she's having pain, the curvature of the spine changes and it becomes easier to modify your technique at that time. A colleague of mine has given us a very interesting thing. What we do is that as soon as we enter the ligamentum flavum, that is when we give the spinal anesthetic. Right, so I'm still in the ligamentum flavum. Over here we start the subarachnoid block. The advantage is that if the patient is moving, at least the epidural needle will not accidentally pierce the dura. Right, so now here I'm giving fentanyl. I'm going to give about 20 micrograms of fentanyl. And after this, I'll again recite the epidural needle into the epidural space and then proceed from there. I have found that there has been no accidental dura puncture with this, and it is something that now we teach to our residents and go on. So the CSE technique, you get a CSE kit where you can go through the needle through needle technique, which you just saw just now, or you can have a 2 needle technique if you're working in a nursing home and you don't have these kits because they're a bit expensive. If I have to do a 2 needle technique, I give the spinal by a paramedian route, and I hope that the needle entry point into the dura would be different from where I'm approaching in the midline. Now, CSE is said to be as safe as an epidural. However, there is an increased incidence of increased incidence of pruritus. Hypotension we have not really seen. What is important is that with CSE you can have fetal bradycardia for the first 5 minutes after you give it. What happens is that as soon as you give intense analgesia, the maternal catecholamine levels go down. As soon as epinephrine goes down, epinephrine actually has a uterine relaxant effect. As soon as epinephrine goes down, you have hypertonus of the uterus, and this is what decreases the placental blood supply and causes fetal bradycardia. Because of this, many people do not advocate giving CSE, and there are sort of limitations to giving it late in labor when you want early initiation of pain relief. But if you are able to load the patient properly and you decrease your the amount of fentanyl that you give, you come down to about 15 micrograms, this incidence goes down. The other thing is that as soon as you have intense pain relief, there can be a chance of a precipitate labor. Now, there have been various techniques. What I have described until now is what we do. But you have intermittent epidural boluses that have been described for maintaining analgesia, continuous infusion of local anesthetic, that is what we do. If you come from a good hospital which have lots of money, you'll have patient-controlled epidural analgesia pumps, whereby you can give the control of giving analgesia to yourself to the patient. There are now features of giving a timed intermittent bolus, that when you know, it is something akin to knowing when the stimulation is going to happen. So as labor increases, you start giving timed boluses to coincide with the increase in pain. And finally, computers integrated patient controlled analgesia pumps are also there, whereby they calculate the previous hour's bolus requirement, increase your next hour baseline infusion, and hope for reduced requirements of boluses. So this is what we have discussed. Okay, so what do you monitor when you have an epidural on flow? You have to frequently assess your patient, see that there is no developing motor blockade. You have to review all the maternal vital signs, see that the fetal heart rate is continuing normally, and keep reassuring the mother and give her quiet encouragement that she can do it. We often tell our patients to go off to sleep or to listen to some relaxation music when they're alone. In the past 2 years, husbands have not been allowed into the labor suites because of COVID, but I think we're about to see them back. So she has to feel that you care about her pain. So when I say that you give a holistic approach, it is not just giving her pain relief through an epidural catheter. She has to feel that you actually care, that she should not have pain. And if she has pain, she has a sympathetic ear. She has somebody whom she can complain to. Your equipments have to be looked after carefully. You have to make sure that nothing else goes into your epidural catheter except the local anesthetic. So it is best to have designated infusion pumps which will be used for epidural analgesia, because the sister should know that these pumps are not meant to be given IV. You have color coding of your infusion lines, where you have the small flags, and make sure there are no injection ports or 3-ways on your epidural lines. And there should be a clear policy who can modify the infusion rate or who can give any medicine through your epidural catheter. We have had instances where we found magnesium being started through the epidural catheter in a patient of PIH. Since then, we made those rules that this thing can only be touched by us. We all know about the side effects of neuroaxial analgesia. Hypotension purported to have about a 13% incidence, but in our institute it's about 2 to 3%. Preloading does not help. You have to co-load, and you should be ready with ephedrine or phenylephrine. I think all of you will be happy to know that phenylephrine is going to come in low dose ampules now, and it'll make it less expensive, probably about 100 rupees per patient. Epidural analgesia is associated with fever. In a normal patient, the temperature can go up by 1 degree centigrade and the cause is unknown. If the increase in temperature is about 1 degree, the mother does not require a sepsis workup, and neither does the neonate. Now, what happens if things go wrong? A beautifully functioning epidural is a godsend, but if it doesn't function, there's nothing worse than that. So inadequate analgesia. If there's inadvertent dura puncture, you can have respiratory depression and the dreaded intravascular injection of local anesthetic. Not to mention what we all know, total spinal anesthesia. Now, if the analgesia is inadequate, first try and increase the amount of medicine that you're giving. Increase the volume. If that does not work, try and increase the concentration of the anesthetic. But before this, rule out any other causes of pain. Make sure that the bladder is not distended. If it is a VBAC, make sure that there is no ruptured uterus. Whatever side is having pain, make sure that that is dependent. And if it is more of a sacral pain, try and make sure that the patient is sitting up and you can give it. But if after half an hour you're still not having any good analgesia, be prepared to change the epidural catheter after a consent. So a good practice is that let the mother know from before. If the catheter does not work, you may have to change it. That way it'll save a lot of complications afterwards. If there has been an unintentional IV injection of a local anesthetic, remember to call for help. You might have to do a perimortem cesarean. Be ready for that. But before that, administer oxygen. Make sure that you follow all ACLS protocols, and every labor suite or every OT that is practicing epidurals should have intralipid emulsion available over there. At least 3 bottles of 100 ml have to be present. Your initial dose is about 1.5 ml of 20% intralipid. Talk about 100 ml that would have to be given over a minute. You continue the infusion at about 0.25 ml. If there is persistent cardiovascular collapse, you may have to give 2 to 3 boluses. Be prepared for that. Now, just a few recent things that have come out which actually help us. Now, we know that there is no increased cesarean rate due to epidural anesthesia. This has been proved beyond doubt. But we know that the duration, the second stage of labor will be prolonged by 1 hour instead of 2. Now prolonged second stage labor becomes 3 hours with an epidural. There is an increased need for augmentation of labor and instrumental delivery. But in instrumental delivery and vacuum delivery has all gone down with low dose epidurals. Now you give an epidural as soon as the mother demands for it. There is no difference in your cesarean rate or the duration of labor if the epidural is administered early. Now, do not go for early pushing. Let the head descend down as much as it can, and only once it is crossed 0 or +1 station, that is when you ask the mother to push. And this is where you have to help your obstetric colleagues and tell them that please do not ask her to push. Very often at about 9 centimeters the epidural stops because she won't be able to push. Now if you want that they should continue the epidural or the mother should be pain free, you will have to be present over there at the time of delivery. If you are present, you can make sure that you continue your epidural infusions so that the mother delivers pain free. But this is over there is a judicious decision. You have to see if she is pushing or not. There is no contraindication for epidurals with VBAC, but be careful that any severe breakthrough pain might signify uterine rupture, and keep a close watch on the hemodynamics. We say that backache is not, epidurals are not a cause of backache, but everybody who undergoes a spinal always points to their back, right? So, but literature says that epidurals do not cause an increase in backache. One thing is, important thing that has changed is that if you have a dura puncture with your epidural needle, please try and insert the epidural catheter into your subarachnoid space. Use that for giving a continuous spinal analgesia, and you can use that for a cesarean section also. The presence of the catheter within your subarachnoid space for about 36 hours will introduce local fibrosis, and it will reduce your postdural puncture headache by about 50 to 60%. Whenever the patient is having a contraction, do not give an epidural top-up, because the increased pressure that is there can directly injure your nerves. So this is what we have found out. Or if there is any paresthesia during injection, please stop or either withdraw your epidural catheter or resite it. Okay. Now what do we do if a mother has to go for a cesarean section? We normally use the same epidural catheter. What we do is, I use about xylocaine 2% with area, about 15 to 20 ml, and I get the effect within 5 to 6 minutes. You will have people citing different combinations of xylocaine with bupivacaine. You should use what is best suited for you. What I am using is what has been validated by a number of trials, and this has been found to be very fast. However, if the anesthetic is not adequate, I go in for a general anesthesia. No half-hearted measures. Either you protect the airway or you don't. And ultimately, this is what we look for. You look for a thank you note from your patient who says thank you very much.
Hello. Dr. Saluja, very nice talk, and I think you are my teacher. डॉक्टर सलूजा ने 20 साल पहले लेबर एनाल्जेसिया गुड़गांव में शुरू किया, जब गुड़गांव में एक भी कॉर्पोरेट हॉस्पिटल नहीं था. It was just a city of few nursing homes, and he has spent sleepless nights to develop this practice in Gurgaon. कर हम भी रहे थे, टुकड़ों में कर रहे थे, लेकिन the way he has started this practice and जिस तरीके से किया, now we have a very long, we have a team. Of course, Dr. Saluja is my senior, he is leading the team. But हमने एक simple एक protocol बनाया, एक strategy बनाया, and we are considered as the safest obstetrician team in the Delhi and NCR. So all credit goes to Dr. Saluja. He is the one who is leading the front. Thank you, Dr.
Beneath
Saluja.
your two kind.
Our next speaker is Dr. Gaurav Arora. He will be speaking about this pre-eclampsia and eclampsia, treating as a perioperative physician. Gaurav is the recent consultant in our team. He is recently promoted as a consultant. He was our best associate consultant, recently promoted as a consultant. Now listen to him.
Thank you, sir. Thank you for
Welcome,
giving me
Gaurav.
an opportunity to present myself over here in front of all the senior faculties. So today, one more important topic, or a matter of fact, that what we face actually in the OR or the emergency room, that is eclampsia or pre-eclampsia. So we'll be learning about how the patient presents to us and how we manage it. The focus will be on how to deal with it in the current scenario or the facilities that are available with us. So classifying the hypertensive diseases, in pregnancy we classify it as gestational hypertension. Pre-eclampsia could be without or with severe features of preeclampsia, with chronic hypertension, and chronic hypertension with superimposed preeclampsia. How preeclampsia is defined? It is defined as an onset of hypertension with systolic blood pressure of more than 140 and diastolic above 90 mm of Hg with a previous normotensive presenting after 20 weeks of gestation. And it could be associated with proteinuria of more than 300 milligram in last 24 hours. With severe preeclampsia, there are some add-on clinical symptoms where the BP is, blood pressure is more than 160 by 110, associated with proteinuria more than 2 gram over 24 hours, thrombocytopenia, changes in serum creatinine level, impaired liver enzymes, and some premonitory signs of headaches, visual disturbances, or pulmonary edema or oliguria. Whereas eclampsia is defined as the occurrence of one or more generalized convulsions in the setting of pre-eclampsia in the absence of other neurological conditions before, during, or after labor. It is one of the most important emergency encountered and it can develop up to 48 hours post-delivery and has been seen up till 10 days of postpartum period. Any women presenting with seizures should be considered as eclampsia until and unless proved. It could be differentially diagnosed with other things, but in a labor, in a obs and gynae setup, we usually consider it as a eclamptic patient. Nulliparity, multiple gestation, maternal age more than 35 to 40 years, obesity, chronic hypertension, diabetes, molar pregnancy, and pre-existing hypertension or renal disease are the common risk factors for this scenario. So coming up to the etiopathogenesis of preeclampsia, or I would say the condition where it develops the hypertension or preeclampsia or going into the HELP syndrome. Due to the endothelial damage, what exactly happens is because of the platelet aggregation and thrombocytopenia, the hemolytic anemia is there, and because of which the liver enzymes are elevated, which results in HELP syndrome. Also, there is a decreased production of vasodilators, which decreases the sensitivity to, there is a decreased sensitivity to the vasodilators, which increase the systemic volume resistance, can lead to hypertension in these patients. Also, with the increased glomerular filtration, glomerular capillary permeability, it leads to proteinuria, which can lead to edema, and which is one of the signs in the preeclampsia or the eclampsia picture. So this is how it affects the different organs where the different factors are released and they affect on the almost all the major organs in the body. What is our role now? Now, what, as a peripartum physician, what we all need to see to it? First of all, controlling the blood pressure, control and prevent further convulsion, establish a clear airway, prevent major complications, and provide labor analgesia or anesthesia for a C-section. So, coming up with a case scenario where a term antenatal periparturient on low bed 100 milligram twice daily presents with ER with high blood pressure record of 200 by 110 mm of Hg. So, when this patient presents, we already know that yes, this patient is already a pre-diagnosed PIH patient, where we will be starting, for the first priority will be managing the blood pressure. We will start with IB lobate with 20 milligram for immediate action and send all the lab parameters. Monitoring of blood pressure should be done for every 10 to 15 minutes, and if still the blood pressure is high, lobate in the aliquots of 40, 80 milligram can be given up to a maximum dose of 220 milligram. Our goal is to prevent maternal sequences and our aim is to decrease the mean arterial pressure by around 15 to 20% with a target blood pressure of around 150 to 110 mm of mercury. Obviously, the obstetrician has to be called upon for the fetal surveillance, and a decision and a consensus with the obstetrician has to be made to deliver or terminate the pregnancy. So these are the primary lab parameters that I will be sending to the lab, because we need to see, because of the pathogenesis that we have discussed, we see various changes in the lab parameters, and the parameters are very dynamic, and we can expect the change in the platelet count or the hemoglobin, and coagulopathy can be seen in around 6 to 12 hours. We can expect changes in the this scenario. So, controlling blood pressure, we have to optimize the patient according to the NICE guidelines. Labetalol, hydralazine and nifedipine will be the first line of drugs. Atenolol, ACE inhibitors and ARBs should be avoided, and to see that nifedipine is to be given orally and not sublingual. Oral nifedipine, let's discuss upon the doses. The oral nifedipine can be used in a dose of 10 to 20 milligram every 20 to 30 minutes for to a maximum of 50 milligrams. Injection labetalol, as discussed, in the aliquots of 20, 40, 80 milligram in a gap of 20 minutes IV can be given. Injection hydralazine is also been advised, but I'm not being using it. 5 to 10 milligram every 20 minutes is recommended to a maximum dose of 20 milligram. And infusion of nitroglycerin at 5 microgram per minute can also be used to a maximum dose of 100 mics per minute. Now, this patient needs to be either taken up for a normal delivery or for a C-section after a proper counseling with the patient. If we go in for a labor analgesia, we have to see certain points. Obviously, labor analgesia gives us a benefit to avoid general anesthesia, and obviously the possibility of airway catastrophe and stress response to airway manipulations. It also helps us in improving the intravillous blood flow. It gives a high quality of analgesia. It reduces the catecholamines and stress-related hormones, and can be used for post-op analgesia and obviously extended analgesia if emergency, the patient lands up for an emergency LSCS. And for some obvious reasons, wakefulness and bonding of mother to the child and exclusive breastfeeding also gives the benefit during this kind of anesthesia. So Dr. Saluja sir has already described about how to give the labor analgesia and the recommended doses. I will not go much deep into it, but this can be practiced safely in patients in a pre-eclamptic setup. But obviously, we need to check on with the coagulopathy prior taking a decision to go in for a labor epidural. Now, the discussion comes where we need to decide upon whether regional anesthesia is better or general anesthesia. Obviously, we need to see upon the clinical symptoms, the presentation, and how urgent the baby needs to be delivered or the pregnancy needs to be terminated. General anesthesia makes it indication in a patient who is unconscious or have uncontrolled seizures later on, or have coagulopathy, severe maternal hemorrhage, or increased evidence of ICP. But what challenges us during general anesthesia are the potential difficult airway, hemodynamic response to laryngoscopy, and effect of magnesium sulfate on neuromuscular transmission and uterine tone. In another case scenario where an antenatal parturient under observation for BP monitoring in ward complains of headache and blurred vision and throws away a seizure in subsequent hour of shifting to high dependency unit. So primarily what I'll do is that we'll see for the maintenance of secure the airway, we'll secure IV line attached with the paramonitors, catheterize the patient for input-output charting, and injection magnesium sulfate taking as a primary drug of line of management in eclampsia or pre-eclampsia setting. I'll be starting with the IV loading dose of 4 gram over 20 minutes. The antihypertensives like labetalol can be started. The obstetric team has to be consulted and a decision for C-section has to be taken. Now if we have to go in for general anesthesia, we'll pre-medicate the patient, pre-oxygenate, and we'll be considering the attenuation of the stress response to laryngoscopy with injection lignocaine 1.5 milligram per kg or injection labetalol 0.4 to 0.8 milligram kg. Rapid sequence intubation with injection propofol 2 milligram per kg and succinyl choline in recommended doses will be done. The anesthesia should be maintained with 100% oxygen inhalation agents until the delivery of the baby, and once the baby is delivered, we'll be starting off with we can reduce the dose of inhalation agents, add nitrous oxide, opioids, paracetamol and other NSAIDs. Adequate uteronics should be used. Obviously methergine has to be avoided, and we'll be going in for oxytocin, and then recently added carbetocin can also be used in a dose of 100 milligram in 100 ml of solution over 10 minutes. Towards the end of the surgery, the patient is reversed, and to attenuate the extubation hemodynamic response, labetalol or esmolol can be used in recommended doses. Now, if a patient who has not yet recovered well neurologically or is not being conscious, the patient needs to be monitored and look out for the further complications. If the unconsciousness persists, further neurological evaluation with EEG and brain imaging to rule out any persistent seizure or other neurologic problems should be performed. Injection magnesium sulfate for next 24 hours at a dose of 1 to 2 gram per hour should be continued. The blood pressure monitoring should be done, and make sure that the diastolic blood pressure is not above 100 mm of mercury. So what actually causes seizures is the loss of autoregulation of cerebral blood flow, which increases the dilates the vessels, and there is some ischemic and increasing, and the vessels become more permeable. The airway obviously needs to be, it's the biggest concern where we can land up into some issues, and the internal, it is all because, so we need to be prepared with all the adequate airway maneuver techniques, and all the small size tubes should be available with us. And because of some physiological changes in this scenario, the internal diameter of the trachea is reduced, which causes to epiglottic edema. The women with preeclampsia can be, these changes can be exaggerated with upper airway narrowing as a result of pharyngolaryngel edema. These changes may compromise visualization of airway landmarks during direct laryngoscopy, so always be prepared with bougie and stellate so as to assist in our intubation. Subglottic edema is one of the one cause of airway obstruction, and other signs and symptoms for like dysphonia, snoring or stridor should be ruled out for airway obstruction, and we should be prepared well for that. So to prevent further convulsions, magnesium sulfate, as discussed, is the drug of choice, and it can be given in 2 different regimes, one being the Zuspan regime and the other the Pritchard regime. The Zuspan regime is the complete IV regime where we load the patient with 4 gram of IV bolus followed by 1 to 2 gram of infusion over next 24 hours. The Pritchard is an combined IV and IM regime where we initially load the patient with 4 gram of magnesium sulfate in over 20 minutes and 10 gram of 50% of max self is given in alternate buttocks, followed by 4 hours, followed by 5 gram IM for every 4 hours in alternate buttock. We need to see, obviously, we are running with the infusion of max self, so we need to see for any magnesium toxicity. The therapeutic level should be maintained, and the normal we consider as 4 to 7 milliequivalent as the therapeutic plasma levels. If a seizure continues or we have another episode of seizure, the second bolus of max self in a dose of 2 gram to 4 gram can be re-administered. If the seizures continue despite the bolus of magnesium sulfate, injection phenytoin or diazepam in the recommended doses can be used. Resistant seizures should be managed with muscle relaxants and, if required, intermittent positive pressure ventilation. So, obviously, the patients in preeclampsia or landing up into eclampsia might present with some renal disturbances where we find the serum creatinine levels are raised. So, there we need to modify our dose of magnesium. The initial bolus dose or the loading dose remains almost unchanged, where we can load the patient so as to attain the plasma levels. But the infusion rates have to be titrated as per the looking after the serum creatinine levels and any signs of magnesium toxicity. So postpartum management, where once the patient has been delivered, obviously patient has been shifted out to the recovery or the high dependency unit. Still, as discussed, the patient can land up with some seizure or any post-op complications for up to 48 hours to up to 10 days. So thromboprophylaxis in a way of TED stocking or compression pump should be applied. Consideration of low molecular weight heparin should be done, and it should be given as per these recommendations. And it should, if the patient has been done under general spinal anesthesia, wait for around 12 to 24 hours after spinal anesthesia to start on with the low molecular weight heparin. And patients with BMI more than 30, multiple pregnancy and PPH are more prone for these things. The fluid management should be well balanced fluid. It's around 75 to 80 ml per hour, and input-output monitoring should be done. Magnesium sulfate will be continuing for 24 hours post-delivery or the last convulsion, whichever is later. And oral antihypertensives can also be added up. The amlodipine and nebivolol are the presently we are using for oral antihypertensives in the post-op setup once the patient is well stabilized. Now, if this patient, when shifted back to the ward or the HDU, complains of difficulty in breathing or falling SpO2, and on examination we find CREPS, so the most probable diagnosis that we come across is the pulmonary edema, where its incidence is around 2.9% in this situation, in the present scenario. The oxygen saturation monitoring, oxygen supplementation either via non-invasive ventilation or intubation needs to be done. The patient needs to be in propped up position, and consideration of intravenous furosemide in a dose of 20 to 40 milligram over 2 minutes is used to promote venodilation and decrease the intravascular fluid. Intravenous morphine in a dose of 3 to 6 milligram IV bolus, and a strict fluid balance needs to be maintained. Oligouria is also being found to see in the postpartum period in the presence of normal renal and respiratory function, usually requires no active treatment. The use of furosemide and low dose dopamine for management of oligouria in women with normal renal function has not been recommended as such. Acute renal failure may occur if there is a pre-existing kidney disease, and indications for hemodialysis include persistent acidemia, hyperkalemia, volume overload and uremia. So by now we all know what all these are, what is PIH, preeclampsia and eclampsia, and we know how to deal with them, how to decide upon whether to go in for a spinal anesthesia, general anesthesia, the airway part, that what all we need to prepare before going in for intubation or giving general anesthesia to these patients, looking after the coagulopathy part, the bleeding, so as to avoid any kind of jeopardy complications regarding to the coagulopathy part. how to manage, how to foresee the premonitory signs of the patient for landing from a preeclampsia state to an eclamptic stage, the managing the pulmonary edema and the oliguria in the post-op or the postpartum period. Thank you all. So one happy team after completing one successful case of a pre-eclampsia landing up to eclampsia case. Thank you. Yes, ma'am. It can be given directly over 2 minutes with a slow infusion, or diluted up to 10 ml.
No,
Not
it's
even
not
that.
recommended. Dilution is not recommended.
Ma'am, we have just started the use of carbetocin
We
as
also started using, so
Yes, ma'am.
we also did some reading.
As
and all
well,
that,
we are
so I
also
just-
trying with different things. Sometimes we are diluting it into a 10 ml syringe, or at times we give it in an infusion of 100 ml.
That is
And,
what we were also doing, but that's not recommended. Specifically mentioned that it not to
Ma'am,
dilute.
I'll take a note of it and I'll try to
Yeah.
integrate in my practice.
So what we are doing is we are taking it in an insulin, 1 ml syringe.
Yes, ma'am.
And then just count for each division 5 to 10 seconds.
Okay,
1, 2,
over a
3, 4,
minute
5,
or so.
6. So it's easy, to give it like that. Or if you want a quicker action, you can always use 3 units syntocinon, say IV bolus.
Yes,
and
ma'am.
after that, give the carbetocin IM, because then
Okay.
it can start acting little later and it will have prolonged action. So there are 2 ways of handling this problem of giving carbetocin.
Sure, ma'am. Thank you so much for updating me, and I'll be trying to implicate this in practice. Thank you. Thank you all.
Yeah, I would like to invite Dr. Chintan Vyas for the next topic on very interesting one. My spinal has failed in an emergency LSCS. What are the options I have now? So just before he starts, I just regarding the PET, some of the facts and myths what we had over the years, traditional teaching, and what are the changes. If you remember long back, the only reason we always wanted to give spinal or epidural in the case of PET for the fear of the hypertension. But if you go to the last CMAC report, the most common cause of death in a preeclampsia patient can guess the cerebral hemorrhage. That is the reason why we should be going more for regional rather than thinking about hypertensive response. Second myth is, we have been traditionally told, if you remember the K.D. Tripathi or pharmacology books, that loop diuretics cause more harm to a PET patient than the other form of vasodilators. But when there is an end organ damage in terms of pulmonary edema or a CNS, keep your threshold very low to give a Lasix rather than holding it back, thinking that you are causing more hypovolemia. Third point I would like to make, the concept of exacerbated response to vasodilator or vasoconstrictor in PET is no more valid. Like for a patient who comes for a labor analgesia or a spinal, we used to the co-loading or preloading, that concept is not that PET patient they will have a more drop, so you should load it more. It's more harmful because it will cause again the hypervolemia, so don't practice giving exacerbated fluid assuming that the BP will fall more. So be responsive than having an action before what happens to that. These are the 3 recent changes I'm sure everyone might have gone through. Just to remind ourselves, these are the things in the PET. Last thing, I can correlate with the last one, the ONSD talk, beautiful talk by Dr. Sumit. So we had a study last year that the biggest decision, if I keep myself out of my anesthesia, for a moment I forget I'm an anesthetist, I'm a perioperative physician who has encountered a patient of preeclampsia. The biggest challenge for me is when to start magnesium. Biggest challenge. So sometimes we have a patient pretty normal, no symptoms, everything, but something changing inside, the present at a time. So this ONSD, is one of the tools last time we used in a study to see a trend. Don't run behind the number, but if you see there is a change in the number, patient saying some vague symptom which you are not able to correlate, gives an early indication, the magnesium we can start. Yes, madam, you want to talk something?
Excellent talk on PIH. I just want to make a small comment. All those patients who've been receiving tablet labetalol for control of blood pressure throughout their antenatal period, and still come with a hypertensive crisis either in labor or for any other reason present to the hospital in that crisis should not be started on IV labetalol. They've already received labetalol throughout their ANC period, will not respond to labetalol. Hydralazine is the drug to give in the first instance to these patients. That is what my experience has told me. Another thing, the Pritchard regime is something which we are actively discouraging, although no gynecologist or obstetrician will listen to you. But Pritchard regime means 14 grams of Magsalf being given at the same time. 5 grams in each buttocks and 4 grams IV. That's 14 grams at the same time, which is disastrous for a patient who's just on the brink with low GFR. It produces an acute renal shutdown. So giving IV magnesium sulfate is a much safer way to go about on these patients. Thank you.
Absolutely agree on that. You have blocked all the beta blockers, so there is no more beta blockers available. So we switch over to hydralazine as early as possible. Okay, sorry, Chintan, it took you some time. Carry on.
Okay. Good morning, everyone. Maybe my presentation will be the briefest. As we all know, that spinal is the to go to the modality for cesarean section in most of the places, be it institute or in a private practice. Being a disclaimer here that I am a freelancer from the beginning. I have never practiced in an institute, so I will be speaking mostly on perspective from the private practice only. So maybe some sirs and all professors here will be finding my talk as a out of context thing, but sorry for that in the outset. I am a freelance anesthesiologist and practicing as a pain physician at Bardoli in Gujarat since 20 years now. We all encounter failed spinal in many cases, and especially in it is an emergency cesarean section. It is a semi-disaster and and it is a big problem for private practitioner actually. So what is failed spinal? It is a failure to provide satisfactory surgical condition to mother, causing discomfort and dissatisfaction during CS, which required conversion to GA. May or may not require GA. So in this, it can be categorized in 3 aspects, that your spinal can be termed as failed when there is inadequate level or there is partial effect of your spinal. Maybe there may be second category where your spinal drug has not acted at all. So patient will be having a total no sensory or motor effect. And there is third, you can call it failed or not. It is a controversy that you patient experience some dragging pain during the surgery. So it also can be termed as failed spinal. So basically what spinal requires to be successful is you have to place correct drug in correct dose at correct place. So these 3 things may fail and your spinal may fail. So it may be issue with your technique. Maybe the person is a bit inexperienced, so they may be fumbling in the emergency setup. Maybe there is issues with equipment, your drug, maybe your spinal needle. So basically what we encounter in clinical practice is you have given too low prick and given a drug which is lesser in volume. Usually bupivacaine you need 12 milligram of dosage. Maybe some novice anesthesiologist is a bit worried and he is giving low dose. So it may have low effect, lesser level, and your final spinal fails. Maybe obstetricians are in some hurry, and there is distress on part of obstetrician rather than the fetus is in distress, and they start early. So they may have given lesser time to block to act. That may be one of the stupidest, you can say, cause. There may be inappropriate positioning where you have given maybe hypobaric drug in a higher place, and you have not tilted your table adequately. So it may fail. Hyperbaric, you may have given a head-up position, and it will have lesser lower level. There may be failure on your part to counsel that there is blood or something has been, and you are suspecting some problem with your spinal. You have to communicate it properly with at least with surgical team. There may be tactical reasons, like your technique is faulty because of some anatomical difficulties or some obesity. There is kyphosis, lordosis, scoliosis. You may have placed your injected at some other place. There is a known entity subdural spread of your drug, where you can find a crazy effect. Level may go down very fast. There is one entity, Taulo cyst, where there is a cyst where you are giving, you are aspirating CSF, but the drug is going in a cyst space, so you will have inadequate effect. There may be issues with your equipment. The needle may be blocked, and especially if you are using pencil point needle, the injection point is a bit proximal, so you may be injecting the drug partially out, so it may lead to low dose in intrathecal space. It may cause your failed spinal. There is a drug potency issue also. We know our manufacturers may be giving us faulty drugs. There may be many drugs which wrong drugs are common, like Trenexa. We have lot of incidences, same ampule, and we are giving inadvertently in intrathecal space. That may cause failure. There may be resistance, as you know, previous scorpion bite and all that thing may lead to. So now a question comes, once your spinal failed, what you should do? Actually, it depends on the urgency of doing a section. If you have time, you can revert to some plan B, which is convenient to you, your surgical team. In a private practice setup, I can say I am more comfortable to repeat my spinal, because I have less backup in terms of helping hands and also the drugs and all that thing. There are stupid things like availability of oxygen and persons to help drugs which are available with you. So if you have the surgical team has not given an incision, and you have failed to recognize that you have inadequate effect, you can have some plan B, like you can repeat, revive, recourse, depending of how much time. Ideally 30 minutes should be given, as literature says, you have to give 30 minutes for your spinal to act, but it is a bit impractical thing. No surgical team waits for 30 minutes. So you have to recourse many times to general anesthesia. You may have to salvage your spinal. By salvaging, I mean to say that you have to change your, you recognize your position of the table is head up. You may be doing a head low tilt and maybe tilting to one side or a thing, and your spinal may level may come up. This is a controversy thing that Valsalva will have some effect. Many old anesthesiologists, including me also, sometimes suggest you do Valsalva. It may help or not. It is a controversy, but it has to be done. Nothing wrong in it. Then there is, and you can always salvage with your IV TIVA, and in that now there is dexmedetomidine we have. So I think it can be combined with ketamine, and it is my go-to drug nowadays. Ketodex I will prefer rather than fentanyl or ketamine or something. Now, by this salvaging, you may be ending up in some unforeseen complication like respiratory compromise, hypotension you may be creating with your spinal effect plus the effects of your propofol, and that you may end up with intractable hypotension. So you should be prepared for that also. There is chances of hypovolemia if patient is not properly hydrated. So these are problems with this salvaging technique. So I will be more comfortable if I have time. I will be repeating my neuraxial block. Actually, by neuraxial block you can have a spinal, you can combine it with epidural, or you can this epidural volume expansion thing. I have never used it, so just a thing to mention. I will be more comfortable in repeating the spinal, but in that I will be choosing different method. Like if I have given first in midline, I will be shifting to paramedian approach. Then I will be choosing different agent. Now we have ropivacaine also. We have maybe you can use lignocaine. I am using it many times, though it is a controversial thing. But I think if your bupivacaine has failed, so you can go to lignocaine. You have short waiting period, plus you can have your effect. Then I will be choosing additive if I have not used in previously. So clonidine, fentanyl, anything you can give. Buprenorphine is also a very good choice. In this aspect, we may be facing complications like the spread of your repeat spinal may have unpredictable spread. It may go up a bit more. You may encounter subdural spread in your second spinal. You may be ending up with very high concentration at intrathecal space, especially in lower region, and you may face cauda equina type of thing. And there is also always a chance of total spinal. I have not seen, so I think it is if you have given many times in our groups we have seen that people are giving full dose 4 ml in spinal for CS. I think you may end up with total spinal in that kind of bravado. You may be ending up with intractable hypotension or PDPH with repeat pricks. And there you may face neurological complications. So still I will prefer spinal to get repeated. So if your all repeat spinal also fails and you don't have time, in like there is a really emergency, impending rupture or fetal distress is there, heart rate is going down fast, you may have to straight away go to general anesthesia. In that we can have safety of our routine GA, like with rapid sequence intubation. But I think IGL GA, SGD GA is I think more safer for private practice, and I am doing it more frequently in case of failed many times we have seen that with total IV also we can manage the things if there is a patchy effect. So again, Ketodex is my go-to thing, or else only ketamine. Third preference is propofol with inhalation agent along with IGL. So in any case, you have to combine it with multimodal analgesia, provide analgesia, enough analgesia, so that patient's satisfaction and the experience of going through CS is pain-free. So you have to add Dexona, paracetamol, NSAIDs, intra plus post-op, and you may have to you should rather supplement with truncal blocks like TAP block, RSP, or erector spiny block. And you may supplement it with epidural post-op. So in this, we may encounter airway problems, aspiration issues, CI/CV situation. Because of multiple drugs, fetal hypoxia may be there. So I think this always there is some issues. So in short, the ABCs of failed spinal management, especially during emergency CS, is admit your failure, be prepared for your plan B, communicate to the patient and the surgical team that you have failed and you have this plan, document these things, the events with your reasoning and subsequent, and explain the consequences for the future thing if there is some issues, and always follow up patient post-operatively, reassure and ensure their well-being and satisfaction. I think that's it from my part. Thank you for listening. Thank you.
Okay, without wasting time, we'll invite Dr. Sai to come up with the next topic, which is a very interesting one and a complicated one to face with. Dr. Sai, please.
Siva, with the permission of this, I just want to say Chintan was my junior. I was JR3, he was JR1. I was very sure that even if the spinal fails, Chintan can never fail. So this is something like a junior-induced tachycardia, which we used to have when he will go on calls. We only know how it was in the hostel when we were waiting, what is the update from the Chintan, whether the case is done or not. So it was a real tachy-ready thing going on when he was on call. But he is an excellent anesthetist. Thank you.
A very good morning. I'm really happy to be here in TASCON 2022. And I'm taking you back to...
Sai, very sorry to interrupt. This is an important announcement from the security wing actually. Some unleft luggage, some unattended luggage is outside, black suitcase. They want to check whether it belongs to us because they need a security clearance on that.
Black briefcase.
Black briefcase, something like that. Just check on. Okay, thanks. Sorry.
So, a very good morning and welcome to TASCON 2022. I'm really happy to be here. I'm working as a consultant anesthesiologist right from the year 2015. So here I'm taking you back to the year 2015 when I was a freshly minted attending consultant at a corporate hospital, and it was my first month and a Sunday morning. So we'll be seeing peripartum cardiomyopathy, diagnosis, management, and what happened that day, my experience. So a simple case of LSCS. I had come to the hospital at around 10 a.m. for this emergency cesarean, And on a Sunday morning, we have very skeletal staff. There's no cardiologist, there are no consultants, just residents, only the anesthetist and the obstetrician. So it was an obese parturient of 120 kgs. She was bearing twins, had polyhydramnios, preeclampsia, and it was a term pregnancy. We were taking her up for fetal distress, and she also gave a history of enoxaparin injections in the thigh, which was stopped one day before. She didn't take it on that day. So coming to the history and examination, it was a precious pregnancy conceived by IVF, detected with preeclampsia in the late second trimester. It was a twin pregnancy, some shortness of breath right from the early third trimester onwards. However, she could do her daily activities of living, and I could see pedal and sacral edema, and her face was puffy. Now, coming to anesthesia and surgery in Rot of Rush, there was a quick cleaning and draping, and I gave GA and intubated her by RSI. One thing that happened was after the delivery of both the babies, there was a transient fall in saturation up to 90-93%, which picked up on its own. The rest of the surgery was uneventful, and I extubated her uneventfully. Then the patient complained of pain, and I gave her diclofenac. After this, there came a twist. We were shifting her back to the trolley to shift her to the PACU, and she became not breathless, apneic. Then I thought it was a spasm, and I immediately took the mask and I gave her a CPAP. She became comfortable. Now again we were proceeding, but again it happened. She had the spasm thing, became apneic, and after the CPAP she coughed up pink frothy secretions. Now, I don't know what went wrong. I was devastated. I quickly intubated her, gave her PEEP, gave her Lasix, and shifted her to the ICU on ventilator. The surgeon was not anxious but fuming. The relatives were angry, anxious, and I was devastated. Then we took her to the ICU. The ICU residents were nice. They immediately did an echo, and there was global hypokinesia, and the EF was 25%. They told me, okay, madam, it's peripartum cardiomyopathy. They reassured the obstetrician that it's not her fault, and then we spoke to the relatives as well and started her. Now coming to the literature, what exactly is this peripartum cardiomyopathy? According to AHA, it's a dilated cardiomyopathy which presents from the last month of pregnancy up to 5 months postpartum, where there is an absence of any structural damage or no other cause can be attributed to it. It unfortunately mimics the physiological changes in pregnancy. It's very difficult to diagnose. There is shortness of breath and swollen legs, and almost all the kind of middle and upper class ladies have swollen legs, shortness of breath, and very little physical stamina, and all the symptoms are vague. However, there's an important clue. Creps in the lungs, there can be tachycardia. If you're fortunate, you can hear S3. I would like to confess I did not auscultate her chest, so I don't know if she had creps. So now coming to our patient, again, the symptoms are vague, fatigue, palpitations. All obstetric patients have palpitations. There's nocturia, and there's shortness of breath, especially while lying flat or with activity, swollen ankles, engorged neck veins, and orthostatic hypotension. Then this is important because according to the NYHA classification, if it's a grade 2, 3, or 4 class of dyspnea, always keep your guard up and stay on alert. Now coming to the pathophysiology, it could be due to viral myocarditis, cardiac autoantibodies. Some say there's an inadequate response to hemodynamic stress of pregnancy. There can be a cardiac cell apoptosis, some cytokine release, and it's often seen in malnourished patients, maybe due to selenium deficiency. There's also cases of familial predisposition, and now recently they attributed to increased prolactin levels. This could also be an effect of excess estrogen and progesterone, and they can be myocardial stunning due to adrenergic surge of labor. It can also be due to some myocardial ischemia. Now, whenever we see these risk factors, we should have a very high index of suspicion. That is older maternal age, which we are seeing very frequently these days, hypertension, high parity, multifetal pregnancy, use of tocolytics in pregnancy, in order to retain the fetus, especially in precious pregnancies, exposure to alcohol or drugs by the mother, and poor nutrition. Now, if we go back to our case, she had hypertension, she had multifetal pregnancy, and it was a precious pregnancy. Now, diagnostic criteria for peripartum cardiomyopathy, it has to have present with a heart failure of any degree in the last trimester or up to 5 months postpartum. The ejection fraction should be less than 45%, and there should be no other cause to attribute to the reduced EF. Now, how will you evaluate this patient? There should be an increased BNP or an N-terminal pro-BNP. ECG is mostly non-specific with sinus tachycardia, some interventricular delay, or LBBB. Now, in echo, there are classical features of a dilated cardiomyopathy: LV dilation, LV systolic dysfunction, RV and biatrial enlargement, and resulting MR-TR, sometimes PAH, and rarely an intracardiac thrombus. Now, the echo criteria for peripartum cardiomyopathy is that ejection fraction should be less than 45%, and diastolic diameter LV should be more than 2.7 centimeter per meter square, and M mode fractional shortening should be less than 30%. This is for classic dilated cardiomyopathy. Now, coming back to our patient, what can I do with all this knowledge in my patient? That day, when I went home, I called my HOD and said, what could I have done? She said, nothing, beta, now you just relax, it's over, na? It's all taken care. But this thing still remained with me, and I was wondering what could I do on a Sunday with skeletal staff in an emergency LSCS, even if I have a high index of suspicion. Now I know that there's something we could do. This is the focused SS transthoracic echo. It is easy, and if you give an hour after your OT, you can learn it. So these are the basic fate views. So there are 5 views. First, we start with the subcostal 4-chamber view. We can see the liver, IVC, and then move it towards the heart. You'll see the RA, RV, LA, and LV. Now, after this, the apical 4-chamber view. You feel the apex impulse and put your probe there. There you can also see the 4 chambers, LA, LV, RA, RV. Now just tilt the transducer a little. In the middle, you'll get the aortic valve. Now this is important. If you can also see the AV. Now one more condition that can present with this Krebs and dyspnea is AS. That can also be seen, at least by just eyeballing. Then coming to the parasternal long axis view. This is the only view in which the transducer has to be pointing to the patient's right shoulder. So here you can see the LV, RV, LA, and the aorta, and LV outflow tract. Then we go to the parasternal short axis view. Just rotate the transducer, and here you can see the RV and LV. In this view, just play a little, you'll see the papillary muscles. At this part, you can nicely eyeball the LV. In this view, you can see if it is contracting well, you can see if there are wall motion abnormalities, and you can see if there is any, in this view, you can see if there is cardiomyopathy or less movement of the LV. So these views, they are just 4 views, and you can also go do the pleural scan, and you can see for the lung movement, and you can see for the presence of B lines if there is pulmonary edema. So this is, when done on a regular basis, you can use it easily. Now look for obvious pathology. See for the wall thickness and chamber dimensions. This comes with practice. Assess biventricular function. See the pleura on both sides, and you can relate this information to the clinical context. This is one thing that can tell you if my patient had physiological changes in pregnancy or she had a cardiomyopathy. Now this is how the views look. At the apical 4-chamber view, we can see the 4 chambers, and we can also open the LV, the aortic valve. Then to the subcostal 4-chamber view, and the plaques and the short axis view. Now, is this useful to me as a non-cardiac anesthetist? Yes. It has been seen that it's fast and reliable in 97% of mixed ICU population. A full FATE protocol after you learn takes only 70 seconds, and the 4-chamber views can be done in 10 seconds. The preoperative FATE by anesthesiologist changes cardiac diagnosis in 67 patients and management in 44%. So after knowing that it's useful to me, how much time will I take to learn it? The learning curve. This is a very good article from which we can see. Then they have seen that a 3-hour training plus 5 hours hands-on training is enough, or 10 one-hour tutorials given to ICU residents, and they are correct 94% of the time, and we can do a regular practice. So once you learn it from the cardiologist or with a cardiac anesthetist, it will be easy for you to practice it regularly. Then coming back to the patient, our patient, she was on ventilator for around 3 days, and then her cardiac failure resolved, and she was extubated and went home uneventfully. Now to see the management of peripartum cardiomyopathy, it's supportive. Now, if it occurs after the delivery or you find it out after the delivery, you can use ACE inhibitors. Otherwise, they're contraindicated in pregnancy. Others are beta blockers can be given, diuretics, digitalis, anticoagulants. Nowadays, valsartan and sacubitril are also tried. And bromocriptine has found to have a role by blocking prolactin. Cardiac synchronization along with these medical management has also been tried. Now what are the DDs? As we saw, it can be due to normal physiological changes in pregnancy. Takotsubo's cardiomyopathy can also present like this: severe preeclampsia or eclampsia, pulmonary or amniotic fluid embolism, previous undiagnosed RHD, ischemic or stress cardiomyopathy. And prognosis, variable long-term outcomes have been seen. 50% improve with treatment, rest 25% either have chronic heart failure or there's mortality. There are definitive predictors of LV recovery after a postpartum cardiomyopathy. If the LV size is more than 6 centimeters or the EF is less than 30 centimeters at the time of diagnosis, then it is a strong predictor of LV recovery. Complications, there can be progression to severe heart failure, there can be cardiogenic shock, arrhythmias or thromboembolic events like stroke, TIA or LV apical clots. Now to the take-home message. History, examination and a high index of suspicion are necessary. Always auscultate for grefts. If you are suspicious, do a FATE examination, call the multidisciplinary team, manage and counsel the relatives. Any questions?
Dr. Sai, we will be taking question in the end of the
Sure,
session. So together, like
Thank
the
you.
previous session.
Thank you.
So we'll move on to the next lecture. It will be maternal collapse, a nightmare for obstetric anesthetists. The speaker is Professor Dr. Anju Singh. She is a very senior obstetric anesthetist. And ma'am, you can start.
Good afternoon, everyone. We're running a little late. I'll try to rush through the presentation, but take heart, there's just half an hour between you and lunch. Okay, so I'm here to talk about maternal collapse. Let me take you through a few examples. A couple of weeks back, 3:30 in the night, you get a call, your resident's frantically on the phone trying to tell you that a patient who was there in the obstetric emergency or gynae emergency has collapsed. She's to be taken for a section, and aa jao. Her only, the technician's calling you, and the only thing they wish to say is, "Ki, madam, aa jao." So before you can get your wits around you and ask, "Ki, kya hua?" she just wants to say, "Aa jao." So when you reach the hospital, the patient is obviously dead. Another instance, this is about a year back. Post-lunch class was going on, as we have a class 2 to 4 for all our residents. And we get a frantic call from the ward saying that patient has collapsed. So you want to know what happened? That patient theek thi, bilkul theek thi, madam kela kha rahi thi, and she went to the toilet and collapsed. So when you go there and see that the patient is still in the toilet, nobody's done anything, and there is a pool of blood around her, and she's obviously dead. Okay, so let's first see what exactly is maternal collapse that we are talking about here. An acute event that involves the cardiorespiratory system with or without involvement of the brain, leading to unconsciousness or sometimes death, duration of this being during pregnancy or up to 42 days following delivery. It can be as simple as a vasovagal or as difficult as a major cardiac event with an unfavorable outcome. The true incidence of maternal collapse is really not known because of lack of data from the underdeveloped or the developing world, but literature quotes the data as ranging from between 0.14 to 6 per 1,000 births. The maternal mortality may be associated with collapse, or collapse may not lead to maternal death. But the data related to maternal death is only the tip of iceberg for maternal collapse. We also need to take into account the near miss which happens in maternal patients, which is actually a woman who nearly died but survived in this duration of pregnancy, childbirth, or up to 42 days after termination of pregnancy. Why are we standing here and talking about maternal collapse? It's a challenge. The mother and the baby are two lives involved in this kind of a collapse situation. And majority of the time, the staff which is dealing with maternal collapse, see, anesthesiologists are absolutely the boss, but they may not be there in all labor rooms at all times or in the maternal wards. So the people who are dealing with maternal collapse, unfortunately, have very little experience of dealing with these kind of patients. Therefore, it is a proven fact that knowledge deficits and poor resuscitation skills are major contributors to poor outcome. What is the good news here is that the rate of survival to hospital discharge after maternal collapse is fairly high, nearly 60%, which justifies appropriate training and preparation. What is also important and different from other collapsed patients is that concurrently, maternal and obstetric treatments must run together. Are there any changes in pregnancy which affect this collapsed patient's resuscitation? Yes. Cardiovascular and respiratory changes which occur in a pregnant patient significantly affect the resuscitation and survival of these patients. Aortocaval compression by the gravid uterus, which reduces both the venous return and affects the aorta and affects the afterload, results in a compromised patient when collapse occurs, which means that the supine position, which is most favorable for resuscitation, leads to significant hypotension in these patients. Also, in pregnancy towards term, the gravid uterus accounts for almost 10% of the cardiac output, resulting in a significant shunt that impairs effective CPR. The respiratory changes like reduced FRC, increased oxygen consumption, increase the rates of desaturation and greatly hinder oxygenation during CPR. The hormones during pregnancy, which increase the airway edema, reduce the the airflow into the lungs. Also, these patients are classically difficult to intubate. Plus, they have an increased risk of aspiration. What is the significance of all these changes? Any core team member who is dealing with a pregnant woman's resuscitation must be familiar with these physiological changes for a better outcome. Also, sometimes the gestational age will affect the resuscitation and the outcome. There are rule of thumb guidelines in centimeters according to the umbilicus, but do you really have time to measure all this when you have a collapsed patient by your side? So, what you need to really know when you're dealing with a collapsed patient who's pregnant is that any patient who's obviously pregnant needs to have her uterus taken off the blood vessels. Is there any risk factor for maternal collapse? Yes, there is a whole list from cardiovascular diseases, comorbidities, obesity, and patients who do not have a proper antenatal checkup. So what do you do with these patients? You must know that these patients are high risk. Can the impending collapse be recognized early in a pregnant patient? Yes, by the use of stratified, validated obstetric early warning scores. The use of early warning scores basically makes the recognition of a deteriorating maternal patient much easier so that timely intervention can take place. The various physiological parameters are recorded and they are graded according to the severity. You can have an escalation protocol whereby once you record these parameters, grade them into color-coded categories, and then have these shown as cognitive tools wherever the pregnant patients are being managed. A lot of variation of these scores are available in literature. A wonderful study by Carle et al. In Anesthesia 2013 had a modified score whereby the discrimination between survivors and non-survivors were excellent. Anybody who's interested can go and read this article. There was also a very nice study published from UCMS regarding the evaluation of early obstetric warning scores. And this paper, which was a prospective study, showed that this early warning scores was 86% sensitive and 85% specific for predicting the presence of maternal morbidity. The other thing you can do when you recognize a pregnant patient at risk as per recommendations is to have a pre-event planning. You should exactly know what you need to do. Prepare for a section, recognize a patient, and make sure that facilities are available for resuscitation of the neonate. So let's first see what an unstable patient looks like. The purpose is not to resuscitate, but to prevent this calamity from happening. Recognition of the unstable patient is by simple physiological signs that precede clinical deterioration. It doesn't suddenly happen कि patient बिल्कुल ठीक था और मर गया. You will have these patients who give you indication that something is about to go wrong. You just have to pick it up. Once you pick up these signs, you can stratify and categorize your patients into a high-risk category. The moment you have a high-risk patient, put her into the lateral decubitus position and do what is known as a primary assessment. It sounds simple, but it's an extremely systematic way of recognizing and managing your unstable patient. It ranges from A to E, the maintenance of the airway, including suctioning, administration of 100% oxygen, establishing an IV access above the diaphragm in an obviously pregnant patient, optimizing the hemodynamics, maintaining the hemodynamics of the mother by giving her drugs and fluids, doing what is known as an AVPU assessment, and an exposure of the patient for an obvious cause of deterioration. Once you recognize and put this patient through a primary assessment, the next step is to do a secondary assessment, which is basically a differential diagnosis to recognize what is the cause of desaturation or hypoxemia or a low BP in your patients. Now, the possible causes of maternal collapse are varied but should be systematically organized. They can be causes which are obstetric or non-obstetric, and you can have your list displayed somewhere so that your residents can rapidly use them as a cognitive aid. The possible causes of maternal, there are a number of mnemonics available from AHA and other organizations, RCOG, but what you need to know as basic providers of resuscitative care, that they all fit into this H's and T's category, which many of you are familiar with. Every cause of this irks my anesthesiologist brain, that right there in the front is A, anesthetic complications, jaise hum hi ne sab patients maar dene hain, you know, it's right at the top. But all your diagnosis fit into this H's and T's category, which every ACLS provider is familiar with. So what do? Many of these sick patients will fall into your category of either having a bradyarrhythmia or having a tachyarrhythmia, but it's not important to learn these algorithms. What is more important here is stop at the second box. It says identify and treat the underlying cause. Once you do this in an unstable pregnant patient, your job is done. Even in spite of our best efforts at times, you have a patient who collapses. And then we go on to the algorithm of managing a collapsed patient in pregnancy. What you must remember here again is that the actions are simultaneous and not sequential. What should you do? It's the standard ACLS, BLS protocol. It sounds so simplistic when I'm standing here and talking, but believe me, when you have a collapsed patient by your side, majority of your residents will forget to do this. So you need to call for help, but as compared to a normal adult patient, what do you mean call for help in a pregnant patient? A maternal code blue is activated, which means that the team which responds to you must have people from probably anesthesia, obstetrics, and neonatology responding together along with an AED. It is recommended that at least 4 members should respond to the BLS call of a pregnant patient. The RCOG guidelines also say that you must have specialized equipment for the mother, for the baby, and for a perimortem cesarean delivery, which should accompany the resuscitation team. Also, it's very important to delegate leadership right at the beginning. You remember that time when the resident is calling at 3 o'clock, there's pandemonium at the back because nobody knows what to do. So whether it's an anesthesiologist who's leading the team or an obstetrician who's leading the team, this must be clarified as to who will take the decisions. The second link of this is doing early chest compression. This is standard, as we know, for all BLS routines. you have no pulse, you have no breathing, you will start chest compressions, but simultaneously while you start the chest compressions, you must document the time of pulselessness. Along with your chest compressions, what is important to do is left uterine displacement. Remember, manual displacement of the uterus is now recommended. Whether you do it from the left side or the right side or a single hand or a double hand does not make any difference. Ensure that you achieve a displacement of about 1.5 inches from the midline. And the beautiful paper which talks about this uterine displacement manually is being published by Dr. Kundra. We've had a fortune of working with him. Many of us have worked with him. It is this paper which is the basis of this recommendation that it should be a manual displacement of the uterus and not a lateral tilt. So after you've started your chest compressions, make sure that the patient is on a firm, flat surface. There was some recommendation few years back that the position of the hands should be slightly higher up on the sternum for a pregnant patient. There is no scientific data to back this claim. The position of the hands is exactly as we have in any other patient in whom we are doing chest compressions. Push hard, push fast, minimize interruptions, and allow chest recoil are still the standard pillars of high-quality chest compressions. What is important in a pregnant patient is that you should maintain left uterine displacement whenever you feel that the uterus is above the umbilicus. Open the airway, provide breaths. While you're providing breaths, remember, in a pregnant patient, attach 100% oxygen, at least 15 liters per minute, and two-handed bag mask ventilation is recommended for a pregnant patient. You may have a defibrillator which is arrived or an AED as is recommended in an obstetric unit, and try to decide whether it is a shockable rhythm or a non-shockable rhythm. The pad placement is exactly in an adult patient as is a non-pregnant patient. Remember that the requirement of energy is the same in a pregnant patient as in any other adult patient, and there is no effect of the DC shock on the fetus. Immediately resume chest compressions after delivery of the shock. You may have a patient who falls into the right side of this algorithm and has a asystole maybe sometimes, and you must remember these algorithms for their resuscitation. Now, while you're doing all this, you should now shift to the algorithm which is specific for pregnant patients, which says that while you continue your BLS and ACLS, it is imperative that you try to figure out the etiology of the collapse. Perform maternal interventions. Important among them is that these patients are the ones where early intubation is recommended, and make sure it's the most experienced provider who does the intubation or placement of the supraglottic device. And once you do that, one breath every 6 seconds is required. Please do not hyperventilate. It is disastrous for the pregnant patient. Cricoid pressure use is controversial and no longer recommended. The IV line, as I've said, should be above the diaphragm. If you've been given magnesium sulfate, stop it. And if there is no ROSC within 5 minutes, prepare for a perimortem cesarean delivery. Now, is it effective? Yes, there are innumerable case reports in literature which says that cesarean delivery is effective. At least the maternal status did not deteriorate during any of these patients where perimortem cesarean delivery was done. Why should it be done? It reduces the oxygen consumption, improves the cardiac output and venous return, and makes the ventilation simpler. So this goal of improving maternal and fetal outcome is to be taken up even if the fetus is dead. If there's a large fetus, large uterus, and the maternal ROSC is not occurring, please go for a perimortem cesarean delivery even if the fetus is dead. Where should you do it? Exactly where the patient is and you're resuscitating the patient. You needn't shift the patient. There is no need to have an elaborate antisepsis. Just take a scalpel, encourage the obstetrician to do the cesarean with the most convenient access where the patient is being resuscitated. Simultaneously, you of course try to diagnose and remove the precipitating causes. Any ACLS intervention? Yes, if your patient survives or probably when she needs, you may give her medications as per the ACLS protocol, which includes use of amiodarone, use of epinephrine. Remember that medications need not be altered because of physical changes in pregnancy, physiological changes of pregnancy, and no drug in this scenario should be withheld on concerns of fetal teratogenicity. Sometimes your patient will survive, sometimes she won't. If she survives, you can take her to the post-cardiac arrest algorithm, where targeted temperature management is recommended for all pregnant patients who have survived the cardiac arrest and have ROSC but may not be responding to your verbal commands. The potential complication of targeted temperature management is fetal bradycardia if the fetus is still alive, and coagulation dysfunction in the mother. You should be aware of this and try to figure it out if the patient is developing these complications. Is there any role of imaging? Sai's talked about use of TEE in these patients who are at high risk. Yes, even if your pregnant patient is collapsed, you have the facilities, you have the expertise. A simultaneous imaging can take place, which helps you reach a differential diagnosis, but this should not be the priority. Your priority should be high quality chest compressions and immediate BLS for a collapsed patient. The outcome for the mother and baby depend on the cause of collapse, the access to emergency care, and more importantly, on the resuscitation by well-trained staff. Majority of the neonates will require active resuscitation, and the fetal monitoring should continue if the mother and baby survive. And remember that if the fetus displays non-reassuring fetal well-being, it is an ominous sign and indicates that probably the mother is now deteriorating. Debriefing, yes, as Dr. Sai very nicely put it, it is devastating for the people who are involved in maternal collapse. At the end of your resuscitation, whether it is a successful outcome or not, a debriefing session is mandatory. PTSD is common in people who survive, even doctors and nursing staff who go through this maternal collapse. Very important to have a debriefing done by a professional to find out not how it went wrong, but why it went wrong. So the take-home message, all the core team members who are dealing with maternal collapse should be well aware of the physiological changes in pregnancy that affect resuscitation. Patients who become ill in the maternal ward or in the labor room should be risk stratified by the use of early warning scores. Pre-event planning is a must. BLS with high quality chest compressions in the supine position with manual left uterine displacement, defibrillation when indicated, and management of the difficult airway improves the outcome. Perimortem cesarean delivery is strongly recommended if there is no ROSC within 5 minutes. Fetal assessment need not be performed during resuscitation, and special training on maternal resuscitation is a must to improve outcome. Thank you so much.
Wonderful and very legible talk, ma'am. Very nice one.
Thank you.
I would like to happy to invite Dr. Purnima Dhar to give another interesting topic on the patient on anticoagulation, how to deal with when they come for normal labor. If you see, the last talk was a very nice one. In 2022, the AHA finally recognized the maternal collapse needs special emphasis. So 2 new algorithms were added in the ACLS this year. One is the maternal collapse and another algorithm for the opioid toxicity. So this shows how important this topic is and exactly justified by ma'am some time back. Thank you.
Thank you everybody, and thank you TAS for giving me this opportunity to be back with friends, old friends. So let me just start. So my topic is that the patient who is booked for normal labor, who is on anticoagulants and antiplatelet drugs, and how will I proceed? So just briefly, the agenda of my talk. So when I have a patient who comes with anticoagulants, I need to know why the anticoagulant therapy, what are the drugs that the patient is taking, what are the problems that I can face with them, what are the guidelines for management, and what are the alternatives to neuroaxial blockade. So this patient is booked for scheduled for a normal delivery, and pregnancy, as we know, is a thrombotic state, and the causes for it also are a few. It's a nature's way of to prevent bleeding. There are increased serum levels of procoagulants, including fibrinogen factors 2, 7, 8, 10, and 12. There's a decrease in the protein S levels. There's an increased resistance to activated protein C in these patients. There's an increase in the plasminogen activator inhibitors, and most important, these patients also have venous stasis because of the gravid uterus, which is pressing on the inferior vena cava. Now, coagulability complicates pregnancy. So the risk of pulmonary embolism is 5 times more in pregnant women, and it's even more in the puerperium, which is about 14 times, as compared to the non-pregnant women of the same age. PE accounts for 14.9% of maternal deaths in high-resource countries, as per the systematic review by WHO published in Anesthesia Analgesia in October 2016. Well, in our country, the maternal mortality, the bleeding continues to be the major cause for maternal mortality. Our maternal mortality is still hovering above 100, whereas, but in the urban population and in the upper strata of the society, hypercoagulability and its problems are again becoming an issue. So pharmacological thromboprophylaxis significantly decreases the morbidity in these patients, but it is at the cost of increased incidence of bleeding complications. So what are the key indications for anticoagulant therapy in pregnant patients? DVT and acute venous thromboembolism if it has happened. Valvular heart disease, especially when the heart valves have been, you have the older generation heart valves. Prevention of recurrent fetal loss due to maybe antithrombin deficiency, antiphospholipid antibody syndrome, your factor V laden, prothrombin mutation. So what are the, so in order to deal with this hypercoagulability, every society, whether it was the American Obstetricians Society for Obstetricians or the Royal College of Obstetricians or Gynecologists or the European societies, all of them came up with their own guidelines for dealing with hypercoagulability in pregnancy. And if you went by the guidelines, the number of patients who would have required thromboprophylaxis varied in all these 3 different societies and colleges and their recommendations. So to improve and get a consensus on it, there was a National Partnership for Maternal Safety, NPS, which met and got a consensus on the so what should be the guidelines for starting anticoagulation for these pregnant patients. So as a result, now according to the recommendation of the NPMS, we will see more and more aggressive and risk-based assessment of obstetric patients, and there will be a higher number of patients who will be coming who will be put on anticoagulants, and this will increase the likelihood that pregnant women will be anticoagulated when they present in labor or they present with an emergency cesarean section. So what are the drugs that are usually used for thromboprophylaxis in pregnancy? These are the common drugs used. Not a very large number of drugs, so it's easy for us to just concentrate on a few, because the newer anticoagulants, oral anticoagulants, have not been tested fully for pregnancy, and so they are still used only in specific, they have very specific indications, only when you cannot use heparin the unfractionated or the low molecular weight heparins. Patients with cardiac heart valves replacement may present with warfarin. Warfarin is not given in the first trimester because of the effect of the teratogenicity that it can cause. But these particular class of drugs are best managed, especially in our country, because it's cheaper also. They will be kept on warfarin, especially if they have arrhythmias, like if they are in AF or something. So warfarin will be another drug that we will need to be careful with if they present with an emergency situation. Out of the antiplatelet drugs in pregnancy, only aspirin is commonly used as of now. And like I said, the novel oral anticoagulants are not in very frequent use during pregnancy. So what are the risks of bleeding? These are the obstetric guidelines. These are the classification by the obstetricians because the bleeding concerns them as well. So the risk of bleeding, so if the patient, depending on the drug that the patient is on, so patients on low molecular weight heparin, whether it's what one must see is whether the patient is on a prophylactic dose or a therapeutic dose. What is the frequency that the patient has been getting? Is the patient on unfractionated heparin infusion, or is the patient on a prophylactic unfractionated heparin, whether it's a bolus dose or an infusion? Then also if the patient is taking concurrent aspirin, as sometimes they may in patients who are with fetal, non-reassuring fetuses, and of course the warfarin. So what is a major concern about these patients? These patients who are coming for a normal delivery, and like Vivek spoke in the morning, every patient has a right to get a labor epidural analgesia, and that is the best. But is it safe for these patients, and how do we manage that? So what are the factors which affect the incidence of vertebral canal hematoma? VCH stands for vertebral canal hematoma. They come up with new, these things for every time. So somebody calls it vertebral hematoma. Somebody calls it something else. So a lot of articles were calling it vertebral canal hematoma, VCH. So a bloody tap during the procedure, multiple attempts, any spinal anomaly or in the patient, and then of course if it's an inexperienced anesthetist and non-adherence to guidelines. So as I said before, neuroaxial block is the cornerstone of obstetric anesthesia and analgesia. But the incidence of, what is the incidence of vertebral canal hematoma? So these are the three large retrospective studies, and there's one very large meta-analysis also. And these are the ones which are often quoted everywhere, and very large sample size in all. And the incidence, as you can see, the incidence in obstetric patients is rather low, despite the fact that very large number of patients received epidural or some kind of neuraxial blockade. And there was another meta-analysis of 4 studies with a database of almost sample size of more than 1 million obstetric epidurals, and they came up with an incidence of 1 in 168,000 of vertebral canal hematoma, which is not very high. And this difference in incidence is even more striking, given that the bloody taps are more common in obstetric patients. And are known to occur in 3% of epidural placements. Because of the venous engorgement in the epidural space, they are more prone to having a bloody tap. Even so. So the incidence of the rate of the incidence of neuraxial hematomas, some people call it neuraxial hematoma, has reduced in the last 10 years. So till 2011, there were many reports in literature, but most of them were when epidurals or CSE or spinals were done, neuraxial blockade was done in patients who were having coagulopathy and inexperience and lack of knowledge of the damage that it could produce, because we were so convinced that every patient has to get a regional anesthesia for a obstetric delivery or a cesarean section. So all case reports of neuraxial hematomas in obstetric patients with altered hemostasis have occurred in the parturients with a pre-existing coagulopathy, such as thrombocytopenia, hemorrhage, preeclampsia, thrombocytopenia, double ho gaya, HELP, etc. At the time of either the epidural placement or the removal, both. Removal was just found to be just as important. But after 2013, the incidence, the hematomas that have been reported have been because of thromboprophylaxis, not so much because, in patients who have coagulopathy, but because in those patients people are now avoiding neuraxial procedures, or they are dealing with them much better. So 2 cases of spinal hematoma which were reported till 2018, between 2013 to 2018 or 19. So there was one patient who received therapeutic anticoagulation, enoxaparin 1 milligram per kilogram twice a day for postpartum pulmonary embolism 3 days after cesarean delivery, performed with a spinal catheter. So the patient had the cesarean done with the spinal catheter. The spinal catheter was removed on day 2, and on the 3rd day, and after 12 hours after the removal of spinal catheter, patient received a dose of enoxaparin, which was exactly occurred as per the guidelines. And on the 3rd day, patient develops a PE, and the dose of enoxaparin is stepped up. And by evening, the patient starts complaining of severe back pain, and they investigated and found patient had a good recovery after the hematoma was evacuated. So there was another patient who had a postpartum patient who developed spinal hematoma after a combined spinal epidural for cesarean delivery and enoxaparin thromboprophylaxis, but she had the patient complained of back pain, and yet a low molecular weight heparin dose was given, which was scheduled, and the pain was a little vague, so it was not exactly attributed to vertebral canal hematoma, and she became she was operated almost, she was referred to a higher center, and even she had a CT scan and an MRI which were wrongly reported as not having a hematoma, and she was referred to a 3rd center, referral center, where they had a relook at the MRIs, and they said that she had a hematoma. Anyway, this patient had a poor prognosis. She was wheelchair bound at the time of publication. So what are the reasons for the low incidence in obstetric patients? So the relatively hypercoagulable state of pregnancy may be protective. Then, so the difference in the incidence was more, the incidence of vertebral canal hematomas are higher in females, and especially the elderly females, where the incidence is the maximum. And so usually the ones who come for orthopedic procedures, typically knee replacement surgeries, and the incidence probably is higher because of the aging spine and lumbar canal stenosis, and they may be having osteophytes, etc. And the epidural also may be a little difficult. So younger obstetric patients, they have a more compliant epidural space and can accommodate larger volumes of blood before the onset of symptoms. And there are MRIs which are done after the epidural blood patch, and they revealed that the blood leaks out through the intervertebral foramina in young individuals. So that probably is the reason why the incidence is low. At least compressive symptoms are low. The bleeding may be quite high in these patients also. So how do you, what do you have to do? So what are the guidelines for safety when you are dealing with epidurals in patients otherwise, or especially with those who are either coagulopathic, maybe borderline coagulopathic, maybe just about coagulopathic, not even coagulopathic, they're just on the borderline of normal, the higher levels of normal, whether it's platelet counts. One thing that is very important to know is how many negative factors are there. Is the platelet count borderline? Is the INR borderline? Is the patient on antithrombotics? So when there are 2-3 factors together, then it's like that cheese passing through that. When accidents happen, it's because there are 2-3 things that go wrong without your realizing. The bad things come together and create a catastrophe. So the recovery of sensory-motor block after cesarean section has been reported typically to occur between 2 to 3 hours after intrathecal bupivacaine and 3 to 5 hours after epidural bupivacaine. So in our hospital, we have a protocol, and I'm sure all of us do have that patients after a spinal anesthesia, they are not shifted out from the recovery room till they start at least moving their toes. So that is something that we must insist on. Even if we don't want to keep the patients for so long in the recovery area, sometimes it may be a good idea to tell the patient that, expect your feet or legs to start moving by so and so time, and if they don't, just alert somebody. So and when if the obstetrician or whoever on the ward goes to look the patient up, they should also be aware that if they look for these signs, and they should escalate, the anesthetist should be informed, so that we can have a look and decide, see what could be the cause. So if the patient has postpartum neurological deficits, how do you differentiate what to do? So watch for the symptoms. Are they confined to the lower body, or are they not confined to the lower body? If they're not confined to the lower body, which is something that happened in that second case, which I was talking about. She had very vague pain all over the back, so maybe that is why it got delayed, the diagnosis. So, but then think of other causes such as PDPH, preeclampsia, and other causes of neurological problems post-spinal. And if it's confined to lower body, consider peripheral. Look at it seriously and think about the vertebral canal hematoma. So when do you remove the epidural catheters? That's also important. And there are guidelines for that, the ESRA guidelines, and the European guidelines. We tend to follow the European guidelines. And the decision making, what do you do in a scenario if you have a patient who is on anticoagulants and the patient has a bloody tap? So you skip the next dose of heparin, whether it's low molecular weight heparin or unfractionated heparin. If the patient is on a combination of low molecular weight heparin and antiplatelet therapy, wait for 24 hours before giving the next dose of heparin, or 24 hours before removing the catheter. If the patient is on a high dose of low molecular weight heparin, such as for treatment of DVT and PE in pregnancy, Again, wait for 24 hours since the last dose of heparin before siting or removing an epidural or a spinal, or giving a spinal. Any other bleeding diathesis, do not consider neuraxial blockade. So what matters is cause no harm more than anything else. And Dr. Saluja was talking about, talking to patients in the antenatal period, and, especially the young mobile nuclear family girls who want to, who are keen to have a labor epidural. Here is a patient where you probably need to do the other way, try to convince them that there are options, and patients have been delivering without labor analgesia since time immemorial, and so concurrent comorbidities and disease severity require flexible approach to optimal individualized labor analgesia, and other conditions that may preclude women from receiving optimal labor neuraxial analgesia, must remember, include those with spine deformities. So talking to the patient is very important, trying to convince them and making them feel comfortable, because they have, again, like I said, they have, like Dr. Saluja also said, they've read up about labor epidural and they want it. So you need to talk to them, give them the other options. Systemic opioids are good options. Remifentanil is going to be available soon in the country, and there are reports, good reports of its use for labor analgesia. We don't have an experience. We have used fentanyl PCA. Sometimes we do use in patients who present with intrauterine death, and where the patient doesn't want to feel any pain, patient is in labor, and we do put them on a PCA with fentanyl or on a continuous infusion so that they sleep through the whole process, which is anyway very painful for them. There is so the studies show a fairly high maternal satisfaction when using remifentanil in labor, and not any significant difference in the APGAR scores. But what is the concern with most studies and with most people who have used remifentanil is that you need a 1:1 nursing, and which may be very, very difficult in our scenario, especially with the number of patients that we have and the staff that we have. So that is a major issue, because hypoxia, bradycardia, even cardiac arrest has been reported with remifentanil use. Entonox, he has already talked about. There are studies with Entonox, comparing Entonox with labor epidural, where the patient satisfaction, if you taking an interview after the patient has been, the baby has been delivered and the patient is comfortable, when you go back and take an interview, many patients have said that the pain relief may not have been that good, but their sense of satisfaction is much better, because this is probably the closest to the natural childbirth that they have. And there are many patients who may want to do this. So it's not just about pain relief. The qualitative analysis of parturient's experience using nitrous oxide for labor analgesia is also is also good in many cases. Of course, many of them may ask for a neuraxial block in between, like he said, around 6 to 7 centimeters when the pain becomes very high. So what is most important is, first, do no harm. Thank you. Questions?
May I request all the speakers to be there on the dais? Question answer round. Very short question answer round can be taken up. DPE over the conventional epidural. Like if I don't want to put anything in the subarachnoid space, should I switch over to DPE with a conventional epidural catheter? Do you recommend that? And the other query is, you were talking about phenylephrine ampules being shortly available at a lesser cost. What is the strength of these ampules that are going to come out?
You get 100 mic.
100 mic is a recommended dose that has to be given as a single shot.
As a single, actually you're supposed to start an infusion of phenylephrine as soon as you give the spinal. What you want to do is you want to prevent the hypotension from occurring, and you want to prevent the distress that the patient will have of suddenly feeling nauseous, and she'll say that I can't breathe, or I'm having pain in my shoulder. All of these signs, you know that the patient is going in for hypotension. So you start your epidural phenylephrine infusion as soon as you give the spinal, titrate the blood pressure, and then see. You just need it for about 10 minutes, not more than that. I think everybody would agree. Mercury, we started using it, but it became very expensive. So now that the smaller, low dose ampules are coming, I think we'll start, Neon is coming out with them. And now it has started. They just said that they're going to introduce it. I think you're talking about an epidural with a dura puncture. Yes, sir. Right? There is a thought that if you're going to puncture the dura, then why don't you put something into it? What is the point of just puncturing the dura and not giving any fentanyl? Either fentanyl is not available, then I agree that don't put anything else into it.
But the idea of DP is that it gives a better block.
It gives a better block because the drug leaks into the CSF.
Yes, precisely.
Right?
So we did a thesis on this, on DPE versus CSE. You know, we compared CSE with fentanyl versus a DPE with only bupivacaine. And what we found was that definitely the pain relief, the onset of action was definitely slower as compared to CSE, which is quite obvious. You're not injecting anything inside, so it's slightly delayed. But it's not very late also. It takes about 4 to 5 minutes for the onset of action with the DPE. And we definitely didn't find the occasional bradycardia that we do see with when we inject the drug intrathecally. Other than that, it was pretty similar, the effect. No, not with the epidural needle, with the spinal needle. But what is important is that if you're using the 16 gauge epidural needle, the Whitaker needle that comes with the Portex set is a 26 gauge needle. And 26 gauge needle, the thinner the needle, the lesser the effect. So you need to use at least best is to use a 25 gauge LP needle. But what we had was this one only. This is the biggest that is available. But if you're using an 18 gauge set, then the 27 gauge needle may not be good enough for this.
My suggestion is that for labor analgesia, most common side effect is that the injection goes IV instead of going intrathecal. And I had experience, I was giving labor analgesia regularly to one of my gynecologists, and she graduated from a smaller nursing home to a larger, newer nursing home where we had newer nurses. They had never seen labor analgesia, and I gave labor analgesia to a patient. I gave the bolus dose, waited for the effect to occur, the pain subsided. I made epidural injection in 50 ml syringe. I connected it. I gave it to the sister to connect it to the infusion pump. She connected it IV, and later on I came to know that the effect was not there, but by God's grace the patient was safe. The epidural infusion of 0.1% bupivacaine was given IV. So we need to be very, very careful when we give labor analgesia. Just wanted to make that statement. Thank you.
Sai, one observation I had, that you talked about bromocriptine in peripartal dilated cardiomyopathy. I just want to mention one thing, that it's not without danger. You definitely give bromocriptine if there is cardiogenic shock, But otherwise, you better avoid it because it is associated with hypercoagulability and patients have developed MI following bromocriptine. So if you are using bromocriptine in peripartal dilatoneuropathy, you should always give anticoagulant. And I want to know one thing from all those who are doing, is there any role of SGLT2 inhibitors in peripartal dilated cardiomyopathy? Because they have come off late in other cases of heart failure. Is there any role of SGLT2 inhibitors in peripartal cardiomyopathy? Any idea?
According to the AHA, took it from the AHA, and according to the AHA, ACE inhibitor can be given,
No.
but only not when she is
SGLT2
pregnant.
inhibitors.
Sorry?
SGLT2 inhibitors.
I don't know.
Yeah, definitely.
You will give these post-delivery. Once the patient has delivered, then you can give ACE inhibitors safely. In fact, they will be added.
No, I am not talking about ACE inhibitors. I am talking about SGLT2 inhibitors like empagliflozin.
DAPA is being used by many centers. That I have been told by one of senior cardiologists at our place that dapagliflozin is being used nowadays for this query DCM in peripartum.
I think people are waiting for the food also, right? So I think we should carry on with this if you, Dr. Sandeep, yeah, please.
So there is something peculiar about cesareans that we remember failed spinal. If I have to look back in my anesthesia practice, I think 90% of failed spinals were related to cesareans. It hardly ever happened with general surgery or orthopedics, even with fractured neck, femur or everything. Most of them were successful, but failed spinal, 90% it's cesareans. I don't know why. In fact, you have enumerated the reasons. My response to failed spinal would be different. For me, it's always general anesthesia. Now imagine a scenario in the cesarean operation theater. You have an anxious patient. You have even more anxious obstetrician. And now your spinal has failed. The only calm person in the theater has a reason to be anxious. So for me, the best option in such a scenario is general anesthesia. Another reason for me choosing general anesthesia would be it depends on the socioeconomic status of the patient. The higher they go on the ladder, the more demanding they become. And if you're failed in one technique, choose another technique, not the other, another space, or midline to paramedian. I would go from, if it's failed epidural, I would go for failed spinal, I would go for GA. I'm a freelance anesthetist, and there is only one chance, there is a second chance, there is no third chance. So my second chance has to be a sure shot one. That's my take. Thank you.
Yeah. Agree with you, sir.
I would like to just add one point here regarding a nurse giving IV in what was intended to be a neuraxial infusion. Actually, I was at one small nursing home type of place which I used to visit. The orthopedic surgeon would always insist on an epidural cannula, and I would say no, and he would start arguing with me over that. But my reason for refusing was exactly this. I said, look, the nurses you have here are untrained people, and I'm scared to think that if I order an epidural infusion and the nurse ends up giving it intravenously, and yes, today we've heard of such an experience. So trained staff is a very vital component. You have to look at what kind of setup you have, what kind of staff you have. Even in big hospitals, I have seen there has been untrained staff. Not that it happens commonly, but I have seen this situation. So,
Dr. Gunn has, I think, raised that same question.
Yeah.
Because it can happen. So it's part of the training. We have to be vigilant, and that's it. And we can go on discussing this thing.
Just 1 minute.
Okay.
So a patient has come for ectopic pregnancy, and during COVID days she was young but had myocardial infarction, and for that she was getting aspirin and Brilinta. So how should we proceed? She was on aspirin and Brilinta, and now she has come up with ectopic pregnancy. And how
Give
should
GA.
Give GA. No,
No,
it's okay,
no.
GA, but what are the chances of bleeding intraoperatively?
There
And
are
how should I-
chances. There would be chances always of bleeding, and that is
Okay.
something that we need to know. When was the last dose of the drug taken? How much is the gap between her having taken the dose and presenting? And what?
GA is fine, ma'am, but what are the chances of means the bleeding of that patient? So that what all precautions means all the platelets we should transfuse the preoperatively to this patient?
No. Unless
nothing preemptively.
ectopic pregnancy, if it's a ruptured one, it's an emergency. You don't wait for all that. You need to go in, clamp the tube, and come out. She will become all right just by clamping the tube. But if the patient, if you have time and you've done the investigations and the platelet count is normal, clotting is normal, then you need not do that. Just see how much time has elapsed from the last dose that the patient has taken. And aspirin in any case is okay even for epidurals. No, we don't need to
Aspirin
stop.
plus
Clopidogrel.
yes.
Yeah, so that's true for any operation, not just
Only
for
the INR is
ectopic
sufficient?
pregnancy.
Only the INR is sufficient?
You can do a bedside TEG.
Yeah.
TEG is
If you-
available
if you
these
have-
days. So
if
if you
you
have
have
TEG
TEG
facilities, you can do a TEG bedside before taking that patient up for surgery. While she's being prepared in half an hour, you will have the report. That will tell you the exact situation of coagulation in that patient.
There's another thing. You have to see if she is ruptured or not. If she is not ruptured, you admit the patient, monitor. They can always give methotrexate if it is amenable to that. Otherwise, let the time go on. Buy as much time as you can. If the patient is admitted, as soon as she starts complaining of a bit of pain, she's taken to the OT at once. But if she has not ruptured, you still have time until then. Utilize that time, and the only drug that will work is 10-xamic acid. That is the only thing that is proven to work.
Thank you, sir.
Thank you.
Clopidogrel never causes torrential bleeding, It's usually an ooze or, increased oozing. And so it depends on the type of surgery that you're doing. If it's an extensive cytoreduction or something, or a prostate surgery where there is a large, a raw area which will continue to bleed and ooze, those are the patients which are a problem. Not ectopic pregnancy. You just go in, clamp, come out. It's a very clean surgery that way. Clopidogrel will not increase the bleeding problem in such a patient.
Thank you very much.
Thank you. A quick moment to presentation session, maybe like I request the faculty to be there. May I request Dr. Aparna to present a memento to Dr. Vineet, sir? Dr. Vineet, please. Dr. Deepika to present a memento to Dr. Sivakota, please. Fast. Dr. Chitra to present a memento to Dr. Vivek Saluja, sir. Dr. Sheetal to present a memento to Dr. Gaurav Arya, please. Dr. Ashu to present a memento to Dr. Chintan, please. Chintan. Dr. Vidya to present a memento to Dr. Ranju, ma'am, please. Dr. Lokesh, please, to present a memento to Dr. Sai. Yeah. Yeah. Dr. Tarun to present a memento to Dr. Purnima, ma'am, please. Thanks. That concludes our session. And please, sorry for having kept you waiting for lunch. But I think then we could know what are the advantages of having a late lunch. Thank you.